Hey guys, this is Joseph Farahani here with Prep for Step, back with another video. But before we get into that, I would like to give a shout out to one of my all-time favorite professors, Dr. John Barone from baronerocks.com. If you're a medical student like I am, you probably already know him. But in case you do not, you should definitely check out his website, baronerocks.com. And I will definitely leave a link in the description for you guys, okay? There's plenty of mnemonics there to help you out with your USMLE exams. Now, my initial intent was to do a brief video, maybe about a 4 or 5 minute video on the menstrual cycle and the hormone regulations. But after getting into it, I realized that there's much more to it than that. So I'm going to try to put everything as a complete review of the menstrual cycle, go over everything that actually happens during the 28 days. And that basically entails follicular maturation, ovulation, all the endometrial changes, fertilization and implantation, although the section on implantation should be very brief. And last but not least, the hormonal regulation of the menstrual cycle. So let's get started. Okay, so the typical menstrual cycle lasts for about 28 days. The first 14 days is often referred to as the follicular phase. Ovulation takes place on the 14th day, and from 14 through 28 is considered the luteal phase. This is hormonally regulated, and initially we're going to discuss follicular maturation in the ovary and then ovulation. Now, this is an ovary, and the concept of the first 14 days is to mature an ovocyte. We're going to take an ovocyte, we're going to turn it into a secondary follicle, then into a Graafian follicle, and on the 14th day with an LH surge or an increase in LH hormone, the Graafian follicle will rupture. The ovocyte will then leave in hope to possibly meet a sperm and become fertilized, and whatever is left will be considered the corpus luteum, which will then secrete progesterone and start the luteal phase. As previously mentioned, the entire menstrual cycle is hormonally regulated, and it all starts with the pulsatile release of gonadotropin-releasing hormone from the hypothalamus. And I said pulsatile, not continuous, because continuous would have a negative effect. So the pulsatile release of gonadotropin-releasing hormone will stimulate cells called the gonadotrophs in the anterior pituitary. The anterior pituitary will then, in response to this, secrete two different types of hormones. One is called luteinizing hormone, or LH. The other is called FSH, or follicle stimulating hormone. Now, if you look over at the ovocyte over here, the ovocyte actually has two different types of cells surrounding it. There are some cuboidal cells here that are called granulosa cells, and there are some flat cells on the outer border which are called the theca folliculi, or the theca cells. Now, LH will stimulate the theca cells, and the theca cells, because of an enzyme that they have called desmolase, will take cholesterol and basically turn it into testosterone. Okay? And on the other hand, the FSH will stimulate the granulosa cells, and the granulosa cells have an enzyme called aromatase, which will take this testosterone and turn it into estrogen. Estrogen plays a major role in the menstrual cycle. Okay, one of the main things that it does is it drives the follicular maturation process forward. It is estrogen that causes the ovocyte to turn into the secondary follicle and eventually turn into the Graafian follicle. So that's one of the things that estrogen does. The next thing is its effect on the endometrium. During the first 14 days, which is called the proliferative phase of the endometrium, it causes hyperplasia and hypertrophy in the endometrium and causes endometrial growth. Okay, so endometrial growth. The next thing that it does is it increases transport proteins and sex hormone binding globulins inside the body. Because testosterone, estrogen, and all these sex hormones are cholesterol derivative, they are fat soluble, and if they're going to travel inside the blood, they are not able to unless they're bound to a protein. Now, estrogen also upregulates certain types of receptors in the body. Okay, so it upregulates receptors, and the majority of those receptors happen to be either estrogen, so receptors for itself. They could be progesterone, and they also could be luteinizing hormone, or LH receptors. Estrogen also has another effect, which is the negative inhibition of FSH and LH. So it blocks, or at least downregulates, the FSH and LH secretion from the anterior pituitary. So what is this Graafian follicle good for? Well, the answer to that is actually twofold. One is that it possesses certain characteristics that are needed in the future for fertilization when the sperm comes around. And 2, it is the remnant of this same graphene follicle that after ovulation remains inside of the ovary and turns into the corpus luteum, thereby secreting progesterone and helping with implantation. Okay? Now, one of the main things that you need to know about the graphene follicle is the certain characteristics that it has. One, it has an antrum. Antrum, I think, comes from the Greek language, and it just means a cave. Okay, this is our antrum. But the more important thing that happens during maturation is the creation of this zone called zona pellucida. And pellucida just means illumination. Okay, the zona pellucida is rich in glycoproteins, and it is these glycoproteins that allow anchoring of the sperm to the oocyte. So it is the glycoproteins inside the zona pellucida that allow the sperm to anchor to the outside of the oocyte, thereby allowing the acrosomal process to take place and fertilization to occur. Okay, so after the 14th day, we enter a new phase called the luteal phase. The luteal phase never changes. It's always 14 days. And the reason they call it the luteal phase is because it is under the direct control of the secretion of the corpus luteum. Now, the corpus luteum, corpus meaning body, luteal or luteum means yellow or saffron color. And the reason they name it that is because its main secretion, which happens to be progesterone, is a cholesterol derivative, fat-soluble steroid hormone, which is, most of the fat is pretty much yellow. Now, progesterone in turn has major effects on the endometrium during the second phase or during the luteal phase. One of the major effects is it causes angiogenesis, or the generation of spiral arteries within the endometrium. Remember, the concept now is to stabilize the endometrium just in case fertilization occurs, so implantation can occur into the endometrium. Okay, so progesterone causes spiral artery development. Progesterone also stabilizes the endometrium by opposing the effects of estrogen. Estrogen wants to cause hyperplasia and divide. Progesterone wants to stabilize. Okay, it also lowers myometrial excitability, meaning that the muscle that holds the uterus will be able to relax in order for it to expand as the fetus grows. It also causes development of endometrial glands, which is critically important for implantation and nourishment of the supposed fetus. And it also increases the cervical mucus, or it causes the cervical mucus to become very thick. And why does it do that? And the reason it does this is because it's trying to actually block any more sperm from entering the tract, thereby increasing the chances of actually one or maybe two sperms possibly fertilizing the mature oocyte. Now, the next topic that we're going to briefly discuss is about fertilization and implantation. We know that the corpus luteum is going to secrete progesterone. Progesterone will then cause the stabilization of the endometrium. But the question that we should ask ourselves is, how long will that last? How long will this corpus luteum be able to secrete the progesterone to keep the endometrium intact? And usually it's about 7 to 8 days after ovulation. So after the 14th day of ovulation, about 7 to 8 days, you will have corpus luteum consistently producing progesterone. Therefore, the endometrium will stay intact. If by any chance fertilization and implantation occurs, then it will cause a positive feedback to the corpus luteum, and the corpus luteum will continue to secrete progesterone throughout the first trimester of the pregnancy. And after the first trimester of the pregnancy, through a process called the luteal placental shift, the placenta takes over secreting progesterone. But now, if pregnancy doesn't occur, if fertilization and implantation does not occur, the corpus luteum will then regress, turning into something called a degenerating corpus luteum, or corpus albicans, which just means a white body. Now it's white as it regresses. Progesterone levels will then fall. As progesterone levels do fall, the myometrium that was actually stable will become excited, and then eventually menses will start to occur, which is exactly why proper timing has always played a crucial role in getting pregnant. It's all based on the progesterone levels. implantation should take place before progesterone levels fall. And that means that fertilization must happen within 1 day of ovulation. So once ovulated, the egg has 1 day to get fertilized by a sperm. When that happens, it is no longer called an oocyte, it is called a zygote. The zygote then goes, for the next 5 days, goes through a series of mitotic divisions without any type of cytoplasmic growth, meaning that the size never gets larger except for the number of cells increases. Okay, until it on day 5 or day 6 it turns into something called a blastocyst. Okay, so around day 5 or 6 after the fertilization happens, the blastocyst, which I kind of drew it up here, you'll have to excuse my drawing, I'm not the best artist in the world. The blastocyst assumes a unique shape. Now it has an inner mass, which are basically embryoblasts, and they will give rise to the embryo later on. And then there is an outer layer. This outer layer actually is composed itself of 2 separate layers. This outer layer is called trophoblast, and tropho just means that nourishment. So these are blast cells that are going to give some nourishment. And you know we're talking about the chorion and the placenta, right? So the trophoblast itself is basically 2 layers. One is something called cytotrophoblast, and the other is syncytiotrophoblasts. Okay, now cytotrophoblasts are always turning into syncytiotrophoblasts by something called fusion. Okay, it's a fusion pathway. Now, so these are our cytotrophoblasts. This is our syncytiotrophoblasts, and syncytium just means something that's multinucleated, means that the boundaries between the cell is gone and there's multiple nuclei within a single cytoplasm. That's a syncytium, and this actually happens for a very, very good reason. The syncytiotrophoblasts, they do 3 things that are extremely important. One is that the reason the syncytium is created in the first place is because maternal white blood cells could technically squeeze in between cells and get into the embryo and attack the embryo. Well, once the syncytium is created, there is no more gaps. Therefore, the maternal white blood cells can no longer attack the fetus. That's one thing. The second thing that they do is they create something finger-like projections called villi. This allows them to dwell into the endometrium and basically hook in there, allowing implantation to take place. The last, but definitely not least, of what the syncytiotrophoblasts do is they secrete something called HCG, or human chorionic gonadotropin. It is this HCG that gives a positive feedback to the corpus luteum, allowing the corpus luteum to continue secreting progesterone, thereby keeping the endometrium intact. So the syncytiotrophoblasts secretes HCG, which is human chorionic gonadotropin. Just a couple interesting facts about HCG is that it is a heterodimeric protein, meaning it is made up of 2 different subunits. It has an alpha and a beta subunit. It is a glycoprotein, which is about, I think, 237 amino acids long. The alpha subunit is about 92 amino acids long. And the beta subunit is about 145 amino acids long. Now, the alpha subunit is identical to the alpha subunit of luteinizing hormone, follicle stimulating hormone, and thyroid stimulating hormone. However, the beta subunit is unique. And guess where we use beta HCG is when we're trying to determine if the patient is pregnant or not. And the reason is the beta is unique to HCG, therefore it cannot be mistaken for, let's say, LH or FSH or TSH. Okay, so to summarize everything that we just talked about, I put everything on just one page so we can compare everything together. And I'm just going to run through it real quick, and hopefully we'll be done. So, in response to the gonadotropin releasing hormone from the hypothalamus, FSH and LH are released. Okay, these are our gonadotropic hormones. FSH usually is a little higher during the 2nd week of the follicular phase. LH usually stays flat all the way until day 14, as you can see a sharp rise in LH. Now, FSH stimulates the granulosa cells in the follicle. The granulosa cells in turn produce estrogen, and as you can see, estrogen keeps going up. Now, estrogen causes follicular development. Also, you can see it causes the proliferation of the endometrium. Estrogen also causes a negative feedback on LH and FSH until right before ovulation, that the increase in the estrogen causes the LH surge and ovulation occurs. After ovulation occurs, the LH and FSH will go flat because there is a negative feedback from estrogen and progesterone and inhibin. So all three of the ovarian hormones are going to cause a negative feedback on the gonadotropic hormones. And the corpus luteum takes over by secreting progesterone. As you can see here, the progesterone levels start to rise all the way up till day 21. If by day 21 or 22 the implantation takes place, that means that the beta HCG is going to be released from the syncytial trophoblast, which will in turn stimulate the corpus luteum to secrete more progesterone. If that does not happen, the corpus luteum will start to regress, the progesterone levels will start to go down, and as you can see, all the glands and everything that were created by the progesterone, high levels of progesterone, will start to decrease, and as progesterone goes down, it causes the increase in myometrial contractibility, and the myometrium starts to contract, and then menses will take place. The last but not least section will be the basal temperature increase, and this is always in the secretory phase or in the luteal phase, if you would, and it's always due to progesterone. As you can see, the basal temperature was 36.4, but now after ovulation, because of progesterone, it has increased to 36.7. On a Fahrenheit scale, that would be, this is a 97.5, and 36.7 will be 98.02. So it just increased just a bit. All right, I hope you enjoyed the video. Please rate, share, comment, subscribe, ask any questions that you might have. I'll be more than happy to answer you if I possibly can. Thank you, and see you guys next time.